Good evening, everyone. I profusely thank Dr. GVK sir for the opportunity. How everybody is waiting for my talk, I know very well. Like we used to wait for the long bell in the school. I hope I'm going to ring a bell. Definitely it's going to increase your curiosity. I'm going to start with a small clinical presentation. A 30-year-old female coming to the emergency department with complaints of vomiting. So the DMO assessed the patient. There is a little bit of dehydration, and I haven't seen CBG. Just he administered one IV fluid and rabiprazole and ondansetron. The patient settled down. She was good. So they discharged from the casualty. After 6-7 hours, they're coming back to the casualty with the same complaints, along with this little bit of breathlessness. Then only they are seeing there is some kind of acidosis, and immediately they did a routine investigation. ABG showed acidosis and urinary ketones, that is positive. Okay, so the treatment started. After some time, they are reassessing the ketones increasing, urinary ketones increasing. Now, what should I do? Should I continue the same treatment, or should I intensify the treatment, or should I reduce the intensity of the treatment? Should I continue? Raise your hands, please. Intensify the treatment? Reduce the intensity of the treatment? Okay. This is where sir would have thought about estimation of ketones as a neglected parameter. We are very seldom concentrating on this one. Usually, this in the particular scenario, the first mistake the DMO made was not seeing the CBG. He missed the diabetic patient. Second one is the decreasing urinary ketones or increasing urinary ketones is a good prognostic marker, because beta-hydroxybutyric acid is more in the blood. When it is coming down, it is converted into acetoacetate that is excreted in the urine. So when increasing titer of urinary ketones is a good prognostic indicator. Let us go into the slides. So we are going to see about physiology, pathophysiology, and fastly what are the clinical conditions which need ketones assessment and all. The glucose comes down and reduces. The body doesn't simply shut down, it adapts. Ketone bodies represent one of the most elegant metabolic strategies in human physiology, enabling the survival during prolonged fasting, starvation, and carbohydrate restriction that happen during our regular fasting, like that, all those things. So when glucose is going below critical level, the free fatty acid metabolized from the adipose tissue and transported to the liver, beta oxidation happens, and from there acetyl-CoA. From acetyl-CoA, then the synthesis of acetoacetate, then from there beta-hydroxybutyric acid and other parameters are coming out. So liver becomes the primary site of ketone body synthesis. Except liver, all the organs in our body utilizes ketones. Liver doesn't utilize ketones. Okay. So these are all the three ketone bodies. Acetoacetate, primary ketone body produced in the liver, serves as the direct precursor for the both beta-hydroxybutyric and acetone synthesis. At the synthesis level, acetoacetate produces beta-hydroxybutyric acid. When resolving level, beta-hydroxybutyric produces acetoacetate. Okay, this acetoacetate present in the urine, beta-hydroxybutyric acid present in the serum, and acetone present in the breath. That's it. So already I told you, the brain ordinarily glucose dependent can derive up to 70% of its energy from ketones during prolonged starvation. A remarkable adaptive mechanism. This is not the pathological condition, this is the adaptive mechanism. So the body can adapt for ketone synthesis until the load overcomes the Krebs cycle's capacity. Up to Krebs cycle capacity, the body can buffer it. When it exceeds the Krebs cycle's capacity, it appears in the blood and becomes the ketonemia, pathological condition. So physiological ketosis is a controlled adaptive state, but when insulin is absent and regulatory mechanism collapses, ketone production spirals into dangerous life-threatening metabolic crisis. So sugar korayudu, glucagon increase agudu, abdiye korudu, acidosis varudu, breathing difficulty is going up, respiratory is increasing, and acidosis affect all the organs, particularly heart, then goes for arrest. That is death sometime, if not revived. So the same thing, insulin deficiency causes hyperglycemia and impaired glucose uptake, uncontrolled lipolysis, floods free fatty acids, and leads to ketone body production. So without insulin, glucose cannot enter cell. So triggering uncontrolled lipolysis and runaway ketone production. So dangers of uncontrolled ketogenesis, you know very well, metabolic acidosis, where pH is following, reducing, Kushmal respiration, and systemic symptoms you know very well. So the dangers of DKA, decay carries a mortality rate of 1 to 5% and requires immediate hospitalization, intensive monitoring. That's why the 5% mortality carries why we should concentrate on assessment or monitoring of ketones. So these things you know very well: fluid resuscitation, insulin therapy, electrolyte replacement, continuous monitoring, everything you know very well. Treating is not a problem, identifying is the problem. So I'm coming to a specific topic: euglycemic ketoacidosis in pregnancy, non-diabetic. Okay, euglycemic ketosis in a pregnancy. It is a hidden danger when normal glucose masks the metabolic crisis. Here what happens? Increase insulin resistance. When insulin resistance increases to the mother, the glucose cannot enter in the mother's body parts. Also, it is getting diverted to the fetus. The fetus is the primary focus in the complex of mother and baby. And there is increased ketone production. Maternal fat breakdown accelerates to compensate for reduced glucose availability. The glucose is one fuel, and ketone is alternative fuel. When this fuel is not available, automatically body switch over to ketones. And the buffer threshold is reduced. The body itself has a buffering mechanism where whenever the acidosis increases, the buffering mechanism will compensate and try to correct the acidosis. When it is not possible, when there is low buffering capacity, definitely it will end up in acidosis. So triggers for euglycemic ketoacidosis in pregnancy: one is starvation, prolonged fasting. Sometimes the prayer la vechupanga inda koilukku varen na ithana naal viradam irukka poren. Those conditions will aggravate your acidosis. And illness and systemic stress. Any simple fever or COVID or typhoid or dengue or any major surgeries, appendectomy, laparotomy, anything, all those things will increase the stress in the women. And pregnancy, sometimes these conditions are very rare but do happen. So diagnostic challenge. Classic diabetic ketoacidosis, glucose will be more than 250. There will be severe acidosis. Obvious presentation will be clinically you can make out she is suffering from some kind of breathlessness. So let us evaluate for acidosis, all those things. And diagnosis will be easy. Other side, euglycemic diabetic ketoacidosis, glucose is normal, less than 250, severe acidosis, subtle presentation, frequently missed, as my DMO missed that patient. So critical implications, you know very well, treatment priorities is very important. Here we should have high level of suspicion. Sandegapattu irukano. So what happens in sodium glucose transport inhibitor treatment? So sodium glucose inhibitor treatment, they are sending the glucose out from the body. So in the body, the glucose level is coming down. Second thing, they are reducing the excretion of sodium as well as ketones. So ketones are coming back to the body. And because of low sugar level, glucagon increases. So again, the same cycle continues. So here, increased ketogenesis, euglycemic ketoacidosis. So whenever the patient is on SGLT2 inhibitor, we should suspect, and there is possibility of euglycemic ketoacidosis. And moreover, one more important point is whenever sometimes whoever taking SGLT2 inhibitor, the alcohol breath test become positive. Be careful while driving Saturday nights. So detecting ketone bodies. So physiology, pathophysiology over, what are all the clinical condition. Even it can happen with the starvation, in exercise also it can happen. Those things are adaptive mechanisms, okay? So detecting ketone bodies. So three places where we can find ketone bodies. One is urine, another one is serum, another one is your breath. Same thing. So traditional approach, urine testing, advantages is inexpensive and widely available, easy self-administration at home, no equipment beyond the dipstick is required. Coming to disadvantages, lower sensitivity versus blood test. If you keep the dipstick for long duration, expiry or before expiry, it may show wrong value. If you are keeping them in inappropriate place, temperature where irukku, veil adikira edathila vekirom, fridge mela vekirom, definitely their results will be altered. Results lack current blood ketone levels. It may not reflect exactly what is happening in blood at that point of time. I may read negative in chronic alcoholic ketoacidosis despite high beta-hydroxybutyric acid. Serum testing is the gold standard. Advantages are measurement of beta-hydroxybutyric acid directly, the dominant circulating ketone. Beta-hydroxybutyric acid is not dominant. Acetoacetate kammiya da irukum, acetone romba kammiya da irukum. So finger prick meters are available, point of care machines are available, very easy. Disadvantages, expensive, frequently you have to prick the patient. That is one problem. So they are rapid results, high accuracy, but at home meters. There are advantages of this gold standard serum analysis of these ketone bodies. This breath testing, non-invasive frontier. So already I told you, SGLT2 inhibitor user must be careful. The advantages, completely non-invasive, no needles or no urine collection, rapid results suitable for real-time monitoring, but disadvantages less standardized. We cannot equalize it with urine or serum assessment. So urine acetoacetate cheap and delayed, blood serum beta hydroxybutyric acid standard and invasive, and breath acetone non-invasive less standardized. Here I want to recollect one point. In type 1 diabetes, fasting ketone bodies will be high. Again, you are going to take food, it subsides. Night before dinner, ketone levels are very high. After food, it subsides. These things are adaptive mechanisms. When it is allowed prolonged period, then the problem occurs. So future, enzymatic platforms, beta hydroxybutyrate, dehydrogenase, NAD, cofactor assessment, redox mediators are there, and specimen types, blood, urine, breath we know, and saliva and sweat are on the line on the research. Wearables, microneedle, and continuous glucose ketone monitoring. Actually, continuous glucose ketone monitoring, we have a few research articles. They are showing promising effect. Those patients, type 1 diabetic patient who are prone for ketoacidosis, they can CGMS mari, we can place the monitor in your the patch in your body. So continuously it can be connected with the mobile phone. We can assess the ketone levels and smartphone integration. So with this, we have to focus on. We have to be highly suspicious. Don't rely on urine ketone assessment alone. Look for the serum ketone assessment. Thank you for the opportunity. Thank you for the patient listening.
So